Hello, everybody. It's a pleasure to participate in this very important project. So I know that this is phase 2 project of recording some important lectures that helps our colleagues pathologists in Ghana in pursuing a higher level of reporting of certain types of tumors. Now, what I'll be talking about is endometrial carcinoma, and I'll be focusing on tips for the practicing pathologist. My name is Maysa Al-Hussaini. I'm a full member, consultant histopathologist at the King Hussein Cancer Center in Amman, Jordan. I'm also the international regional advisor for the MENA region at the Royal College of Pathologists. So this is the outline of my topic. It looks like I'm going to talk about many things, but they will fall, as you will see as we go on, just perfect in place, the way the reporting for endometrial carcinoma should proceed. But before we start, we have really to understand why in particular endometrial carcinoma is becoming more and more important. And just a glimpse at the incidence and mortality of endometrial carcinoma globally. Endometrial carcinoma ranks as the 6th most common cancer in females globally. It accounts for the 13th cause of cancer-related death in females in general globally. Now, if we look at the 5-year prevalence of endometrial carcinoma, according to GloboCan 2020, endometrial carcinoma becomes the 5th most common prevalent cancer in females globally. Now, what is really important to notice is that there seems to be a difference in the incidence of endometrial carcinoma across the globe, being more common, more prevalent in better developed countries, in the States, in Europe, to a lesser extent in Australia. In our region, in the MENA region, for example, and in large parts of Africa, endometrial carcinoma incidence does not seem to be increasing. However, if we really look into the trends of the incidence of endometrial carcinoma worldwide, there is a prediction of increase in the incidence to more than 50% worldwide by 2040. And much of this actually increase, it will be harbored by countries in high income countries or better developed world. However, if we look into the map, the heat map of the mortality related to endometrial carcinoma, we start to see that the numbers in our region, in particular in the Middle East, for example, and in large parts of Africa, actually precedes that of the mortality rate in the better developed world. And actually, it appears that the mortality to incidence ratio of endometrial carcinoma remained at high levels in low and low middle income countries, although the mortality in general has decreased at the global level. So this is why it's very important to keep in mind that the incidence of endometrial carcinoma is increasing globally. The outcome of endometrial carcinoma is improving in better developed countries. However, this is not the case when it comes to countries with limited resources, and thus the importance of discussing the proper handling and reporting of endometrial carcinoma by pathologists. Now, moving into the risk factors, what are the main risk factors associated with endometrial carcinoma? As we all know, some risk factors are well described for a special type of endometrial carcinoma referred to as type 1 endometrial carcinoma. I'll be alluding to this more as we go on in the lecture. So it's obesity, decreased physical activity, and diabetes appear to be associated with increased incidence of endometrial carcinoma, especially type 1 endometrial carcinoma. What is really becoming exceedingly important is that with extended life expectancy that is witnessed globally, the incidence of endometrial carcinoma appears to be increasing as well, albeit it's usually type 2, the more aggressive type 2, rather than type 1 endometrial carcinoma. And of course, in some instances where there is the excess use of estrogen that is not really coupled with the progesterone, appears to be associated with increased risk of endometrial carcinoma. When it comes to genetic predisposition, the best described association is with Lynch syndrome. Around 3% of all endometrial carcinomas appear to be associated with Lynch syndrome, and 10% of those are associated with mismatch repair deficiency. Now, if we focus a little bit more into Lynch syndrome, or what was previously known as hereditary non-polyposis colon cancer syndrome, we know that it is an autosomal dominant cancer predisposition syndrome occurring or affecting 1 in 300 individuals, usually 4th to the 5th decade of life. And we know that there is heterozygous germline mutation affecting one of the mismatch repair proteins, and then this is followed by somatic loss of the remaining wild allele. Now, when we focus on endometrial carcinoma in particular, the risk for the development of endometrial carcinoma within the subset of Lynch syndrome appears to be 20 to 60% in excess of the general population, and usually the affected patients, affected female patients, are usually in their late 40s or early 50s. Remember, please, that the hereditary non-polyposis colorectal cancer is associated with type 1, not type 2 endometrial carcinoma. Another very important factor that should be mentioned always whenever we're talking about reporting of endometrial carcinoma is staging. And we know that we have two staging systems. One is the FIGO staging system, and the other is the TNM staging system. Now, what is the difference between both systems? FIGO staging system appears to be more widely used in the clinical setting by the oncologist or by the surgeons. And it's sometimes used in pathologists, by pathologists, but not that frequent. It is the system that is used in most clinical trials. And please remember that if a neoadjuvant treatment was received by the patient, then FIGO system or FIGO staging cannot be utilized or appear in the pathology report. Now, in comparison, the TNM staging system has both clinical and pathological arms. So it is the one that is mostly used by pathologists, but can also be used by a clinician, and it is the one that can be used whenever neoadjuvant chemotherapy or radiotherapy is utilized in comparison to the FIGO system. And this is very important difference that we should always mind whenever we report endometrial carcinoma. Now, there is a kind of equation or equivalency between the TNM categories and the FIGO staging. So it's very important for any reporting pathologist to have this simple table available beside the reporting microscope. For example, I always mention this in my lectures. For example, with the TNM staging system, we know that the T stands for the tumor, N stands for the lymph nodes, and of course the M stands for distant metastasis. Now, this does not appear in the FIGO system. For example, with lymph node involvement, the tumor is staged as stage 3C. So there is not really direct translation between the FIGO system and the TNM system, but there is an equivalency that any reporting pathologist should be aware of. Now, remember that anytime we receive a hysterectomy specimen or a DNC specimen for the reporting of endometrial carcinoma, this should be accompanied by the requisition form containing as much clinical details as possible. These would include the presentation modality, for example, postmenopausal bleeding, or if the patient was premenopausal, if the presentation was through menorrhagia, prior history of adjuvant hormonal treatment, especially in relation to any personal history of cancer. In this particular instance, any personal history of breast cancer is very much important, as I alluded to before, family history of cancer in relation to Lynch syndrome really helps in establishing or in supporting the diagnosis. Now, the kinds of specimens that are received by the reporting pathologist can be either biopsy or resection. So what is the difference and how we should, as pathologists, deal with both types of biopsy? Now, classically, the first test that is performed for a female patient presenting, for example, with postmenopausal bleeding is transvaginal ultrasound. And if the thickness, the combined endometrial thickness is less than 5 millimeters, millimeter, this is considered like almost exclusive of the diagnosis of endometrial carcinoma. However, if the thickness is more than 5 millimeter, then the oncologist or the gynecologist will perform biopsy that can range between the DNC biopsy, the office procedure, and hysteroscopy. And there seems to be good correlation between the three types of biopsies, as well as the results of these biopsies with the subsequent hysterectomy. Now, for the hysterectomy specimen, it's extremely important to identify and to be knowledgeable about the types of resection a pathologist might receive. The most common type of hysterectomy specimens that we receive are simple hysterectomies or total hysterectomies, whether this is total abdominal or total hysteroscopy-based laparoscopic hysterectomy. And with the total hysterectomy as the interrupted orange color line here, we receive usually the uterus, including the body of the uterus, the fundus, and the cervix. What is usually received most often in cases of endometrial carcinoma is radical hysterectomy, which would include, in addition, the left and right parametria, as well as part of the vagina. Now, occasionally, we might receive subtotal hysterectomy in which the body and the fundus of the uterus are received without cervix. This is considered to be incomplete surgical resection for the cases of endometrial carcinoma. It's very important to note, and you should always request to be acknowledged as a pathologist whether the hysterectomy was performed through an open laparotomy or through a laparoscopic procedure, because of some associated artifacts with a laparoscopic hysterectomy that I'll be alluding to towards the end of the lecture. So for endometrial carcinoma, the usual specimen that is received consists of total hysterectomy with bilateral salpingo-oophorectomy. And remember here, most often we stopped using the obsolete term total abdominal hysterectomy, because nowadays many of those hysterectomies are performed through laparoscopic rather than through laparotomy or open hysterectomy or open procedures. Then we always would expect the presence of pelvic lymph node dissection, para-aortic lymph node dissection, in addition most often to omentectomy, peritoneal biopsies, and peritoneal washings, plus bladder and bowel biopsies. Now, it's very important for the reporting pathologist to be aware of the grossing of the endometrial carcinoma. The integrity of the specimen is extremely important. As I always tell our multidisciplinary team, the MDT team, with which I work closely with, that please do not open the hysterectomy specimen, because the tumors are usually very friable. They would just contaminate. They will be present on the surface. I can never be sure whether this is a true involvement of the surface or just contamination because of improper opening of the specimen. So please insist always to receive the specimen integral, closed, not previously opened. We have to give the dimensions. We always try to ink the outer surface, especially in relation to the parametria and the margins, the resection margins. Most often would include part of the vagina. We have to notice the site of the tumor, whether it's involving the body, the fundus, or the lower uterine segment. And the lower uterine segment is extremely important to note because of its association with mismatch repair deficiency or Lynch syndrome associated tumors. Then we try always to describe the tumor, give the dimensions. If myometrial invasion can be measured grossly, other sites of involvement, and extremely important to have the blocks submitted from the tumor designated, proper designation of the blocks submitted or from the whole specimen in case the pathologist wanted to go back and take more sections from certain areas of the tumor. So careful grossing is extremely important as it will impact the microscopic reporting in endometrial carcinoma. Now, whether this is a DNC specimen, an office specimen, or a hysterectomy specimen, Sometimes we encounter not the full blown picture of carcinoma, but we encounter precancerous lesions. What is becoming very well described in the WHO most recent publication 2020 of endometrial hyperplasia. Now, endometrial hyperplasia, according to the most recent publication, is divided into only two subtypes: endometrial hyperplasia without atypia versus endometrial hyperplasia with atypia or atypical hyperplasia. So endometrial hyperplasia without atypia is usually related to unopposed estrogen with increased endometrial to gland stroma with some abnormal forms of the glands. Frequently, we tend to see the telescoping gland in a gland, as well as branching and longitudinal and horizontal dimensions or directions of the glands. Very important to note that wherever you go within the microscope on the slide looking for the cytology, usually the cytological features are uniform. And this is extremely important to notice in endometrial hyperplasia without atypia in comparison with atypical hyperplasia. Now, why it's important to report and acknowledge the presence of endometrial hyperplasia without atypia? Because it is associated with up to 4 times increase in the risk of endometrial carcinoma. Usually it is in the form of well-differentiated endometrial carcinoma. Now, in contrast, the endometrial atypical hyperplasia or endometrioid intraepithelial neoplasia is associated with a prolonged estrogen exposure, yet it affects a clone. It's a clonal expansion of neoplastic glands. So against what appears to be normal glands, there will be some clonal proliferation with increased gland to stroma ratio. And in comparison, this is a normal endometrial gland, and this is an endometrial gland associated with atypical hyperplasia or an early endometrioid intraepithelial neoplasia, where you see that the size of the nuclei is several times the size of the nuclei in the normal. Mitosis is abundant. The cell itself has abundant acidophilic cytoplasm. So this difference in the cytological appearance is an important clue that we are dealing with hyperplasia, in particular atypical hyperplasia. Now, atypical hyperplasia, in contrast to the endometrial hyperplasia without atypia, is associated with up to 45-fold increase in endometrial carcinoma. And if patients are left they might develop endometrial carcinoma in up to 1/3 of the cases. So whenever we evaluate endometrial hyperplasia, we have to look into two important features. First, the architecture. Are we looking at uniform disruption of the architecture with telescoping and abnormal directions of the glands versus the clonal proliferation of the atypical glands against what appears to be normal endometrium? And then we have the cytological features, whether the abnormal cytology is uniform throughout the slide. This is more with endometrial hyperplasia without atypia versus what I just described as the clonal proliferation, contrasting the normal adjacent to the abnormal glands. Now, looking at the histological classification of endometrial carcinoma, more like the classical histological classification of endometrial carcinoma, we have been we have been practicing reporting endometrial carcinoma into either type 1 or type 2. Type 1 is the usual type associated with the previously described endometrial hyperplasia because it is the one associated with estrogen excess, obesity, and hormone receptor positivity. Usually this is associated with an early stage and low grade at presentation, and it is associated with favorable outcome. Now, this is in contrast to type 2 endometrial carcinoma, which is better known as the non-endometrioid type of carcinoma, usually seen in the older non-obese individuals or females, not associated with excess estrogen exposure. However, unfortunately, this type is the one that is associated with worse outcome and more aggressive course of the tumor. Now, recently the WHO classification also tried to group the morphological subtypes which comes under type 1 endometrioid carcinoma versus the non-endometrioid carcinoma. Now remember that endometrioid carcinoma with the squamous differentiation, showing some secretory features, the villoglandular appearance, the ciliated cell variant, mucinous variant, accorded and hyalinized type of carcinoma, all come under the endometrioid carcinoma, which is the better prognosis type 1 endometrioid carcinoma. Now, for the worst prognosis or the bad players of endometrioid carcinoma are the non-endometrioid carcinoma. This includes serous carcinoma, clear cell carcinoma, carcinosarcoma, undifferentiated or dedifferentiated carcinoma, and some rare types of endometrial, non-endometrioid carcinomas. Now, this kind of classical histological classification has survived for over 50 years. It was very useful for educational and epidemiological purposes. However, one of the most important drawbacks that there were some overlapping features, especially when it comes to high-grade, grade 3 endometrioid carcinoma versus the group, the type 2, the non-endometrial carcinoma. This has led to some thoughts of trying to reclassify endometrial carcinoma for better consensus between the reporting pathologists. And the whole idea of the molecular classification of endometrial carcinoma that I'll be alluding to shortly has come into the surface. When reporting endometrial carcinoma, especially the endometrioid type endometrial carcinoma, we have to assign a grade. And the grading system depends simply on the presence of solid non-squamous component within the proliferating malignant glands. So we assign the grade 1 or the late grade tumor if the solid non-squamous component accounts for less than 5% of the tumor volume. Grade 2 when the solid non-squamous component accounts for up to 50% of the growth of the total growth of the tumor, and the grade 3 or high grade endometrioid carcinoma when more than 50% of the tumor is composed of solid non-squamous or non-morular solid growth. Now remember that the presence of high nuclear features within the context of a grade 1 or a grade 2 would automatically upgrade the tumor 1 grade. So in a grade 1 tumor in which the nuclei appear to be more aggressive and of higher grade, the tumor would be automatically graded as a grade 2. Now, as we go with the grading, of course, the severity of the poor outcome and the severity of the treatment would increase as we go on with the solid component, as we increase, and there is increase in the solid component of the tumor. Now, one important drawback for the grading system is that there was not more than moderate inter-observer agreement, especially when it comes to the low-grade tumors. Then there was the suggestion of moving from the 3-tier into the 2-tier grading system, where we would combine the low-grade, grade 1 and 2 into one low-grade endometrioid carcinoma, leaving the high-grade endometrioid carcinoma as a grade 3. And apparently this high-grade endometrioid carcinoma appears to be more closely linked to type 2 endometrial carcinoma. So the type and grade of endometrial carcinoma should be provided by the reporting pathologist, as this this has an important impact on the treatment as well as the outcome. Now, more recently, with the movement towards the precision medicine and molecular classification of a tumor, a group in Stanford in 2013 published the first molecular classification of endometrial carcinoma, and it appears that endometrial carcinoma falls into 4 molecular groups. If we look at the ones here at the periphery, the polymutant or ultramutant endometrial carcinoma appears to be the least common, but the one associated with excellent outcome, versus the one that appears at the very end of the group, which is copy number high. This is usually serous type carcinoma or serous type like carcinoma, and this is associated with the worst outcome. Now, the 2 groups in between, the MSI associated or high perimutant and the copy number low, appear to be associated with intermediate outcome. This is the one that is most often associated with the mismatch repair deficiency and frequently with Lynch syndrome. And this is the one, the diagnosis, the exclusion, diagnosis of exclusion. So if the tumor is not polymutant, it's not MSI mutant, and is not copy number high, ultimately this will be the copy number low endometrioid carcinoma. It's important, very important to notice that the survival outcome appears to be extremely different, especially between the poly and the copy number high, while, as I alluded to, both of the MSI as well as the copy number low appear to have intermediate prognosis. Now, if we look deeper into the molecular classification of endometrial carcinoma, there is some excellent correlation with morphology. Now, the poly type of carcinoma or mutant, ultramutant endometrial carcinoma is the one that is associated with excellent prognosis. The only drawback is that this can only be detected through molecular testing. There is no immunohistochemical surrogate markers that can detect the polymutant tumors. On the contrary, the MSI and the copy number high can be detected through immunohistochemistry. Copy number high is usually associated with TP53 mutation with the surrogate P53 immunohistochemistry having an excellent correlation with the mutation status, and this is the one that is associated with the poor prognosis. Now, the MSI are the ones which are associated with the mismatch repair deficiency. So we have our mismatch repair protein immunohistochemistry that can be utilized in order to predict or the diagnosis of the MSI associated. As I just explained, the copy number low is a diagnosis of exclusion. There are some markers that are being described more and more in this group of tumor, yet it cannot, there is no one specific marker that can be utilized to render this diagnosis with confidence. Why is it important to correlate or try to molecularly subclassify the endometrial carcinoma? Because there appears to be an improved prognostic relevance and a lesser amount of interobserver variability when compared to morphological classification. And importantly, there is less emphasis on a grade. So polymutant tumors, which are the excellent players within the endometrial carcinoma, regardless of the grade, some of those tumors show marked pleomorphism, nuclear atypia, and usually, but yet they are still associated with excellent prognosis. So it appears within the molecular classification, a grade becomes less and less important. And of course, this has all impact on the treatment of the patient, because if a patient, for example, is diagnosed with polymutant endometrial carcinoma, as I just said, regardless of the grade, the patient actually, if the patient has low stage tumor, the patient can be saved the treatment. There is no need to have adjuvant treatment for those individuals. In the MSI or mismatch repair deficient tumors, now regardless of the grade, again, those patients benefit from immunotherapy in particular. And so this type of diagnosis might help patients, especially with recurrent tumors, in receiving more advanced and personalized type of a treatment. However, as we all know, in the context of countries with limited resources, this classification cannot be always rendered. And there has been some attempts at looking at surrogate markers in order to try to simplify the molecular classification and make it more affordable within the context of countries with limited resources. And as I just explained, we try to go with immunohistochemical surrogate markers, the mismatch repair proteins, and the p53 together can help us sort some of the more important types of tumors, the more aggressive tumors with the p53 mutation, and the tumors that can benefit from immunotherapy in the context of the MMR deficient tumors. Now, once we classify the tumor into the type endometrial, endometrioid versus endometrial, non-endometrioid carcinoma, and then we assign the grade, which can only be applied to endometrioid carcinoma. The type 2 non-endometrioid carcinoma are all by default high grade. We have the next step is to assess the myometrial invasion, and when looking at myometrial invasion, we have to look at both the depth and the pattern of invasion. Now, previously we used to divide the myometrial invasion according to the depth of invasion, whether this is confined to the endometrium, to the inner third, middle third, or outer third. However, the more recent FIGO anti-NM stage moved from this older subdivision, and what we are interested now in is whether the tumor occupies 50% or less of the myometrium, or shows myometrial invasion, versus into the outer half or more than 50% of myometrial invasion, because this would impact the stage into stage 1A or 1B. The way this is usually done, we measure the distance from the reconstructed adjacent normal endometrium into the deepest part of the tumor. We provide the percentage of the involvement, and then we provide what we call the tumor-free distance, which is from the most advanced edge of the tumor into the serosa, and this seems to be associated with poorer outcome if the tumor involves more than 50% of the thickness of the myometrium, as well as has implication on lymph node metastasis. What is really important to notice as well is for exophytic tumors, we don't measure the part of the tumor that protrudes into the endometrial cavity above the line of the endometrium. Again, we measure the depth of invasion from the adjacent normal endometrium into the deepest part of the invasion, regardless of the part of the tumor that is exophytic. So we do not take into account any part of the tumor that is exophytic growing into the lumen of the tumor. What is also important and has been recently revised is the tumors associated with or arising from foci of adenomyosis. Previously, we used to measure the distance from the tumor to the area of adenomyosis, and then in correlation with the thickness of the myometrium, we would describe this as a stage 1A or stage 1B. This is no longer the case. The way now we deal with foci of adenomyosis is depending on where the adenomyotic focus is present. If it's in the inner half, then this is assigned, the tumor is an adenomyotic focus in the inner half, this is considered to be PT1A. If it's in the outer half, the adenomyosis focus that is involved by tumor, this is automatically considered to be stage 1B, regardless of the distance between the invasion and the adenomyosis. Now, there are several patterns of myometrial invasion. The infiltrative pattern is the most commonly identified, the most common one that we encounter. Please remember that there are 3 other patterns, one of which is similar to the adenoma malignum, in which tumor cells or tumor glands infiltrate the myometrium without associated desmoplasia or stroma. It's very important to recognize, because sometimes the glands can deceptively look benignish, and so the depth of invasion can be underestimated. Also remember, please, that there is another pattern of invasion, which is the pushing or expansile pattern, and we have to measure the depth of invasion and the distance to the stroma from the most advanced part of the tumor. And the most recently described pattern of invasion, what is known as the microcystic, elongated and fragmented pattern, or the MELF pattern, in which small aggregates of tumor cells are associated with myxoidish stroma and lymphocytic infiltration, and they appear deceptively benign. So once we identify this pattern, what I usually do is I perform immunohistochemistry, cytokeratin 7 in particular, to confirm the presence of isolated tumor cells or small groups of tumor cells, to confirm the pattern of the diagnosis as well as the depth of the myometrial invasion. Lymphovascular invasion, again, is very important to report whenever we encounter a case of endometrial carcinoma. And the way we report it is that it's absent, or there is a lymphovascular invasion. What has been recently requested is actually to also comment on the extent of the lymphovascular invasion, whether this is focal or extensive. Now, the number of vessels involved varies between the WHO or the College of American Pathologists and the International Society of Gynepathologists. So the WHO requests 5 or more vessels to be involved in order, lymphatic vessels to be involved in order to render the diagnosis of extensive or substantive lymphovascular invasion, while the CAP, for example, and the Society of Gynecological Pathologists require 3 or more vessels to render this diagnosis. Now, remember that lymphovascular invasion does not upstage the tumor if it's present in the outer half or near the margin, while the bulk of the tumor is present in the inner half. So lymphovascular invasion does not change the stage of the tumor. Also, lymphovascular invasion in ovarian, hilar, or parenchymal vessels or tubal vessels without, in the absence of stromal invasion, also does not upstage or the tumor or change the stage of the tumor. Now, why it's very important to report on the number of the lymphatic vessels involved? Because of the recent updated FIGO, ESTRO, ESP guidelines, in which tumors that are considered to be stage 1 but with substantive or extensive lymphovascular invasion, regardless of the grade or the depth of invasion, are considered to be high to intermediate risk, and these patients should be treated actively. Now, it's very important to note that sometimes artifacts can happen, especially if the hysterectomy was opened without fixation prior to fixation, or importantly during laparoscopic surgery. This is why I mentioned at the time of grossing that it's very important for the pathologist to be aware whether the surgery was done through an open route or through laparoscopic surgery, because there seems to be an increased incidence of artifact bulging of a tumor or fragmentation of the tumor into the vascular spaces, and the clues that can help to sort out this very important piece of pitfall is the presence of fragmentation, the presence of normal tissue within the vessels, the presence of tissue cracks,
or vascular invasion or around the tumor. Importantly, if there is disproportion between the size of the tumor, the grade of the tumor versus the degree of vascular invasion, this should be a good clue that the potential of an artifact is there, and perhaps this should be clearly noted and written explicitly in the pathology report. Lower uterine segment involvement, it really matters. Now, it's not part of the formal staging. However, if the depth of invasion of the endometrial carcinoma is more in the lower uterine segment than in the body or the fundus of the uterus, then the depth of invasion in the lower uterine segment should be recorded, regardless of the depth of the invasion of the tumor in the body of the uterus. And it's very important always to differentiate between involvement of lower uterine segment versus cervical involvement, because involvement of the cervix would automatically upstage the tumor into stage 2. Remember that lower uterine involvement is extremely common in tumors with mismatch repair protein deficiency or Lynch syndrome, and they actually are associated with increased incidence of lymph node metastasis and involvement. For the cervical involvement, if the cervical stroma is invaded, this is the tumor is considered to be FIGO stage 2 or PT2. The tumor can show an infiltrative versus expansile pattern of a growth. Some centers or practices would require measurement of the depth of invasion and whether this involves the inner or outer halves of the cervical stroma. Some people would recommend also providing percentage of cervical stroma involvement as well as the absolute depth of cervical stroma invasion. We usually provide these details in our pathology report. Now, the surface involvement or a crypt invasion used to be important in the old FIGO and the TNM staging, in particular FIGO staging. So crypt invasion used to be staged as FIGO stage 2A. However, since 2009, this has been deleted, and we only look at the presence or absence of cervical stromal invasion. It's very important to differentiate from tubular endometrial metaplasia, and although it's not part of the formal staging yet, it is associated with an increase in the incidence of loco-regional recurrence, and some centers would advocate for treating patients locally with brachytherapy to improve survival. Uterine serosal involvement, if there is a breach of the uterine serosa, the case or the carcinoma would be staged as a 3A or PT3A. It does not have to be only a direct invasion or breaching of the mesothelial cells. Involvement of the submesothelial fibroconnective tissue would suffice to render this diagnosis. For the adnexal involvement, the uterine and fallopian tube involvement, this is actually is also very interesting because there is some debate in the literature whether the presence of endometrioid carcinoma involving the endometrial cavity as well as the ovaries and fallopian tubes unilaterally or bilaterally would qualify as two independent synchronous primaries, or one is actually metastatic from the other. And this has extreme important implication on the management of the patient because the stage would be completely different. So if we're considering a case of endometrial carcinoma with ovarian metastasis, the stage would be 3A. This is usually more encountered in cases with high-grade tumors like serous carcinoma. Synchronous primary tumors involving the endometrium and the ovary most often is associated with endometrioid carcinoma, usually low-grade, low-stage, and both actually the primary tumor in the endometrium as well as the primary tumor in the ovary are assigned FIGO stage 1 independently. This is one good clue for the possibility that the patient might harbor Lynch syndrome. What are clues that can help to sort out this debate, whether these are synchronous, independent synchronous primaries or metastases from the endometrium to the ovary? There are several pieces of information that can be utilized to help sort out this debate. For example, the size of the tumor. Usually, to render the diagnosis of synchronous primary tumors of the endometrium and the ovary, both should be of a small size. Sometimes they show similar morphology, but for example, the endometrium in the background will show endometrial hyperplasia. The ovary in the background will have endometriosis. There should be no evidence. There should be absence of lymphovascular invasion or a tubal invasion. The presence of nodular growth pattern, for example, would be associated with metastasis versus uniform involvement of the ovary. However, more recent evidence from molecular studies, in particular methylation study, has suggested that what we used to consider synchronous primary tumors of the endometrium and the ovary are in reality endometrial carcinoma with metastasis. So it seems that regardless of the grade of the tumor or the stage of the tumor, both the presence of endometrial carcinoma with ovarian metastasis would favor that the ovarian tumors are metastatic rather than independent primaries. Parametrial and paracervical involvement or invasion are extremely important because these would automatically upstage the tumor, as is the case with the vagina. Now, the story with the vagina is slightly different because vaginal involvement at the time of diagnosis appears to be uncommon and is associated with, when it occurs, associated with poor outcome. However, involvement of the vagina appears to be more common with recurrence. It's actually the most common site of recurrence and does not affect the outcome. The margins, again, it depends on the type of specimen that is received, whether we're receiving the radical hysterectomy, the simple hysterectomy, or the subtotal hysterectomy. So anything actually with the dotted line is considered to be a margin, and this should be specified in the pathology report. Parametrial margin involved or not. This is independent of parametrial invasion or not. So there is a difference between the parametrial invasion, in which the tumor will be within the parametrium, or parametrial margin invasion, for example, in which the tumor will be exactly at the site where the surgeon cut or loosened the uterus from the adjacent tissue. So it's extremely important to report on the margins, which would include the parametrium as well as frequently the vaginal margin. Most often we will receive the hysterectomy in association with the adnexa, so frequently there will be no adnexa related margins. Now, the bladder and bowel biopsies, it's important to specifically mention whether the serosa or the mucosa of the bladder and bowel biopsies are involved. Involvement of the serosa would keep the stage as stage 3A. Involvement of the mucosa would upstage the tumor into stage 4A in the FIGO system, M1 in the TNM system. Omentum is frequently also removed, and involvement of the omentum is considered to be stage 4B in the FIGO stage and consistent with M1 in the TNM stage. If by examination no gross tumor deposits could be identified, it is recommended to submit at least 4 to 10 blocks in order to look for microscopic foci of a tumor invasion. Now, the peritoneum, we usually receive biopsies from the peritoneum as well as cytology. Cytology does not affect the stage of the disease. It's important to report in endometrial serous carcinoma. However, the peritoneal biopsies are extremely important to report the involvement versus the absence of involvement and the site of the peritoneal biopsy. So peritoneal biopsy involvement within the pelvis would stage the patient as 3A, while in the upper abdomen, this would consider to be 4B or distant metastasis. So it's important for the pathologist to follow a systematic way of reporting the pathology specimen to avoid missing some items, and using data sets helps to improve the reporting tremendously. Now moving into the lymph nodes, which are usually submitted separately and are divided between the regional, which are the pelvic lymph nodes, and the non-regional, anything outside the pelvic lymph nodes. So it's important to remember that lymphatic drainage system for the lymph nodes, for the uterine lymph nodes, the sampling follows the lymphatic drainage system, and we have three groups of lymph nodes that should be sampled. As a minimum, any enlarged or suspicious lymph nodes should be removed in all patients, and for high-risk patients, complete pelvic lymphadenectomy and resection is really recommended. Now, more recently, there is a growing body of recommendation on utilizing what is known as ultra staging for lymph node processing. And this is kind of similar to what we do with sentinel lymph nodes in breast carcinoma. So we divide, we section the lymph node on the by the longitudinal axis into sections separate by 2 millimeters apart. We submit these in total. We examine one H&E and one immunohistochemistry for a number of sections, and then after that, we can say whether the tumor is, the lymph nodes are involved or not involved. This is known as a sentinel lymph node ultra staging system. Now, for the reporting of the lymph nodes, we have to, as I mentioned, we have to describe the group of the lymph node that is examined. So pelvic lymph node involvement would qualify the tumor as FIGO stage 3C1 or PN1, while para-aortic lymph nodes would upstage the tumor into FIGO stage 3C2 or N2. We have to give the dimension of the largest metastatic deposit and the presence of extracapsular extension. It's also very important to mention the degree of involvement, whether it's no evidence of a tumor involvement, there are isolated tumor cells less than 200 cells or less than 0.2 millimeter in size, the presence of micrometastasis, which is defined as tumor cells 0.2 to 2 millimeter in size, or macrometastasis if the tumor deposit is more than 2 millimeter in size. We consider pelvic lymphadenectomy adequate whenever we have almost 10 lymph nodes identified. Now, within the pelvis, frequently we receive fragmented lymph nodes. So in that case, we just try our best to mention the number of fragments and the number of involved fragments if these are involved. Please remember that inguinal lymph node involvement would qualify as metastatic disease, distant metastasis, considered to be FIGO stage 4 or PTNM M1. Now, this is the way the isolated tumor cells would appear. Frequently, these cannot be detected on the simple H&E slice. This is why it's recommended to utilize immunohistochemistry, in particular cytokeratin, to look for isolated tumor cells whenever we utilize the sentinel lymph node ultrastaging. The micrometastasis, again, sometimes can be very deceiving, but the presence, the utilization of immunohistochemistry can better highlight the tumor cells. And remember, micrometastasis, the tumor cells or the group, whether individual tumor cells or a group of tumor cells, should be collectively less than 2 millimeters. One important pitfall is the presence of endosalpingo juices in the lymph nodes. These are not, of course, considered to be metastases. And important clue is that we identify cilia at the apical part of the tumor of the endosalpingo juices. So proper grossing and dissection of lymph node is vital in determining the stage of the disease and thus the need for any further treatment. This is why the emphasis on lymph node examination. Do we advise for performing frozen section in uterine or endometrial carcinoma? The only time that a frozen section is accepted within the context of endometrial carcinoma is examining sentinel lymph nodes, and this is actually what we practice here at King Hussein Cancer Center. We do not advise for examining or submitting sections to examine the myometrial invasion at the time of a frozen section. Now, the last thing that I want to mention is, do we really need to have a large battery of ancillary studies? And if so, when these are needed? Now, there is a growing list of a large number of immunohistochemistry that can be utilized to support the diagnosis of endometrial carcinoma, and also sometimes to predict the subtype and probably in some occasions the treatment response as well. So if we look into the utilization of immunohistochemistry in the context of differential diagnosis, for example, endometrial carcinoma high grade versus uterine serous carcinoma, the presence of p53 mutation really would support serous carcinoma versus high grade endometrioid carcinoma. The presence of deficient mismatch repair protein immunohistochemistry would support endometrial carcinoma versus serous carcinoma. For example, in the differential diagnosis of endometrial carcinoma versus cervical adenocarcinoma, P16 immunohistochemistry as well as ER/PR and mismatch repair protein very helpful to support the diagnosis of endometrial carcinoma versus cervical adenocarcinoma. Now, more recently, especially for the aggressive type 2 carcinomas, in particular serous carcinoma, there is increased recognition and utilization of HER2 new expression and thus targeted treatment for patients with serous carcinoma. And this is reported in around 1/3 of serous carcinoma cases. The patients actually respond beautifully to trastuzumab targeted treatment, and an algorithm has been developed for the initial testing and reporting of the HER2 new expression in high-grade serous carcinoma, in endometrial carcinoma. Now, it's very kind of similar to what is utilized in breast carcinoma, and in cases of unequivocal testing, then we resort for FISH, looking for the amplification of the signal in order to subdivide the cases into the positive and negative for HER2 new expression cases. So in conclusion, I hope I was able to show you or to present to you an evidence that endometrial carcinoma shows an increase in incidence globally, and more cases of endometrial carcinomas and hysterectomies are expected to come land on in the pathology departments on requesting pathologists to report these cases. The classification of endometrial carcinoma is evolving. We're moving now from the classical classification, histological, morphological based classification and grading into molecular classification with the utilization of some surrogate immunohistochemical markers. This can be achieved in low middle income countries as well. Molecular classification of endometrial carcinoma has been introduced and will probably be replace the old morphology based classification and grading. And as we move along with the classification, the role of pathologists have evolved over the years. So the pathologists now are expected to not just only confirm the diagnosis, they have to classify. They play important role in staging of endometrial carcinoma as well as in risk stratification. And predictive markers are important for better personalization of endometrial carcinoma treatment. These are my references, and thank you very much for your attention.